Physiology and pathophysiologies. Mechanics of breathing. Air is moved into and out of the chest in a process called ventilation. To move air, the diaphragm and the muscles of the chest are contracted and relaxed to change the pressure within the chest cavity. This changing pressure inflates and deflates the lungs. Inhalation is an active process. The muscles of the chest, including the intercostal muscles between the ribs, expand at the same time the diaphragm contracts in a downward motion. These movements increase the size of the chest cavity and create a negative pressure. This negative pressure pulls air in through the glottic opening and inflates the lungs. Conversely, exhalation is a passive process. That is, it occurs when the previously discussed muscles relax. As the size of the chest decreases, it creates a positive pressure and pushes air out. Because it is passive, exhalation typically takes slightly longer than inhalation. As we discussed in the chapter titled Ventilation, Perfusion, and Shock, Understanding Pathophysiology, the amount of air moved in one breath, one cycle of inhalation and exhalation, is called tidal volume. A normal tidal volume is typically 5 to 7 milliliters per kilogram of body weight. The amount of air moved into and out of the lungs per minute is called minute volume. Minute volume is calculated by multiplying the tidal volume and the respiratory rate. So, minute volume equals tidal volume times respiratory rate. Recall that ventilation, inhalation, and exhalation is ultimately designed to move air to and from the alveoli for gas exchange. However, as noted in Ventilation, Perfusion, and Shock, Understanding Pathophysiology, not all the air we breathe reaches the alveoli. For example, a 100 kilogram adult has an average tidal volume of roughly 500 milliliters. Of that 500 milliliters, only about 350 milliliters reaches the alveoli. The remainder occupies the trachea, bronchioles, and other parts of the airway, the area known as dead airspace in Figure 10.1. The alveoli are the only place where oxygen and carbon dioxide are exchanged within the bloodstream. Therefore, the air in the dead space contributes nothing to oxygenating the body. The term alveolar ventilation refers to how much air actually reaches the alveoli. So alveolar ventilation is the amount of air that reaches the alveoli. Ventilation is breathing in and out, inhalation and exhalation, or artificial provision of breaths. Figure 10.1, dead airspace. Dead airspace areas of the airway are outside of the alveoli. So everything that is contained in the trachea and bronchi is part of the dead space. The pink is lung tissue. The kind of tan colored parts are the alveoli gas exchange areas. Of course, alveolar ventilation depends very much on tidal volume. Consider the following example. An asthma patient has a normal tidal volume of 500 milliliters. Today, however, because of his asthma attack has constricted his bronchial tubes, he can only move about 300 milliliters of tidal volume. If the air in the dead space remains constant at 150 milliliters, then only 150 milliliters of air reaches his alveoli per breath. So his normal tidal volume is 500 milliliters times 16 breaths per minute, or 8,000 milliliters. Normal alveolar ventilation is 350 milliliters. It's 500 minus 150 dead airspace times 16 breaths per minute equals 5,600 milliliters. Asthma attack tidal volume is 300 milliliters times 16 breaths per minute equals 480 milliliters. Asthma attack alveolar ventilation is 150 milliliters, which is 350 minus 150 dead air space, times 16 breaths per minute equals 240 milliliters, 2,400 milliliters. Remember that alveolar ventilation can be altered through change in rate as well as by changes in volume. A person breathing too slowly will have a decreased minute volume, so the amount of air reaching the alveoli per minute is decreased, just as it would be decreased by a reduction in tidal volume. So a normal minute volume, 500 milliliters times 16 breaths per minute equals 8,000 milliliters. But a slowed minute volume of 500 milliliters times 8 breaths per minute equals 4,000 milliliters, half as much. Occasionally, very fast respiratory rates may decrease minute volume as well, not primarily because of the rate, but because the faster rate can affect the tidal volume. Fast breathing can at times limit the amount of time the lungs have to fill and therefore decrease tidal volume. Even though increasing the rate should increase minute volumes, exceptionally fast breathing will actually reduce minute volume and alveolar ventilation. Physiology of respiration. Inhaled air fills the alveoli. The pulmonary capillaries bring circulating blood to the outside of these tiny air sacs, where the thin walls of the alveoli and the thin walls of the capillaries allow oxygen from the air in the alveoli to move into the blood to circulate throughout the body. The thin walls of the capillaries and alveoli also allow carbon dioxide to move from the blood into the alveoli to be expelled during an exhalation. The movement of gases from an area of high concentration to an area of low concentration is called diffusion. The diffusion of oxygen and carbon dioxide that takes place between the alveoli and circulating blood is called pulmonary respiration. Carbon dioxide is offloaded from the blood into alveoli, while oxygen from the air in the alveoli is loaded onto the hemoglobin of the blood and transported to the cells. At the cells, through a similar but reversed process of diffusion, oxygen passes from the blood across cell membranes and into the cells, while carbon dioxide from the cells passes into the blood. The diffusion of oxygen and carbon dioxide that takes place between the cells and circulating blood is called cellular respiration. Remember, for this entire process to be working, the respiratory system must be appropriately matched up with a functioning cardiovascular system. The respiratory system must be moving air in and out of the alveoli, and the circulatory system must be transporting adequate amounts of blood between the cells in the alveoli. These two systems, working in concert, are often referred to as the cardiopulmonary system, and also referred to as ventilation-perfusion match, as a ventilation-perfusion VQ match. As was discussed in Ventilation, Perfusion, and Shock, Understanding Pathophysiology. When either of these systems fails, the process of respiration is defeated. So diffusion is a process by which molecules move from an area of high concentration to an area of low concentration. Pulmonary respiration is the exchange of oxygen and carbon dioxide between the alveoli and circulating blood in the pulmonary capillaries. Cellular respiration is the exchange of oxygen and carbon dioxide between cells and circulating blood. Pathophysiology of the cardiopulmonary system. Before proceeding, take a few minutes to review the concepts of pathophysiology of the cardiopulmonary system that were discussed in detail in Ventilation, Perfusion, and Shock, Understanding Pathophysiology. Consider the following mechanical failures of the cardiopulmonary system that may occur. Mechanics of breathing disrupted. If the chest cannot create the necessary pressure changes, air cannot be moved in and out of the lungs. Breathing can be disrupted by a variety of causes, such as a patient stabbed in the chest. When the diaphragm moves downward, air is pulled into the chest cavity through the stab wound, in addition to the normal drawing in and out of air through the glottic opening. Because of the air rushing into the chest through the stab wound, a negative pressure cannot be created to efficiently pull air into the lungs through the normal airway passages. Another example is a patient loses nervous control of respiration. A patient may lose the ability to transmit messages through nerve tissue to innervate the muscles of respiration. This can occur in diseases such as myasthenia gravis and multiple sclerosis. Another example is a patient sustains a painful chest wall injuries. Pain and physical damage can both limit chest wall movement. A patient has airway problems, such as bronchoconstriction. If air cannot move, breathing cannot occur. Some diseases, such as asthma and chronic obstructive pulmonary disease, or COPD, which is common in people, I'm just inserting this note, it's common in people who are lifelong smokers, can cause bronchial tubes to decrease in diameter and limit the amount of air that can flow through them. Gas exchange interrupted. Sometimes the ability to diffuse oxygen and carbon dioxide is impaired. Consider the following examples. Low oxygen levels in the outside air, such as in confined space rescue situations. Here, there simply is not enough oxygen in the air breathed in. Diffusion problems. Some diseases, such as congestive heart failure and COPD, can limit the ability of alveoli to exchange oxygen and carbon dioxide. Here, oxygenated air and blood reach the alveoli, but the alveoli themselves are not working. Circulation issues. There can be problems that prevent the blood from carrying enough oxygen to the body's cells, such as not enough blood. If a person has lost a significant amount of blood, not enough blood can be circulated to the alveoli. If blood is not present at the interface with the alveoli, oxygen and carbon dioxide cannot be exchanged. Hemoglobin problems. Occasionally, respiration can be impaired if there is not enough hemoglobin, the oxygen-binding protein in the blood. For example, anemia is a disease that causes low amounts of hemoglobin in the blood. In other situations, as with a patient whose body pH becomes very acidotic, sufficient hemoglobin may be present but may have a difficulty in holding oxygen. When hemoglobin fails, oxygen cannot be transported.